than 160 and diastolic more than 100. So this is the 4 stages for blood pressure. Normally it should be blue 120/80. From 120 to 140, this we call it pre-hypertension. If the systolic from 140 up to 160 and the diastolic from 90 to 99, this is stage 1. Above 160 and above 100, this we call it stage 2 hypertension. So according to the Joint National Commission number 8, this is the latest one, American and European Hypertensive Society, this is the category of hypertension. As in front of you, from blue 120, blue 80, normal, pre-hypertension, this is the reading. Stage 1, as I said, more than 160 or more than 100, this is stage 2 hypertension. For hypertension per se, as a disease, one of the most common health problem worldwide. All over the countries, all over the regions, this is the most common disease worldwide, is hypertension. In a state only, in United States, up to 1/3 of United States population are hypertensive. You can imagine in one study in 2016, up to 60 million American hypertensive patients. So hypertension is a very common disease. The problem in hypertension, most of hypertensive patients are uncontrolled. Because patient not taking medication, not compliant to medication, patient he does have obesity, he does make lifestyle modification. I will come through later on. So the most common health problem is hypertension. It can affect up to 1/3 of United States nations. And the problem in hypertension, most of the patients, as I said just before, are asymptomatic. Most of hypertensive patients discovered accidentally when we check the blood pressure in the clinic or at home, whatever the place. Most of hypertensive patients. That's why it is very, very important during every visit for the patient to check the blood pressure. It's very, very important. Whatever the symptoms of the patient coming with even diarrhea, coming with joint pain, check blood pressure. Okay, just a measure. Okay, so hypertensive is usually asymptomatic. That's why it's called silent killer. How to evaluate hypertensive patient and which patient to give treatment. Not all hypertensive patient needs a treatment. This is very, very important. If you check my blood pressure now, as I said, and you check my blood pressure, I am 170/100. You will give me medicine? No. Unless this blood pressure, the reading is persistently elevated, more than 6 visits, up to 2 or 3 months. It is almost persistently elevated. But only one reading, you cannot depend on one reading. That's why don't check blood pressure in 3 situations. If the patient, he or she, under stress, whether this stress physical or mental stress, don't check the blood pressure. It will be high for any one of us. If I'm under physical or mental stress, automatically the blood pressure, it will be high. Don't check blood pressure after eating, full stomach. It will be high. Don't check blood pressure if you don't have enough sleep. It will be automatically high. That's why when you check the blood pressure, the reading correct, patient should be totally smooth. He doesn't have any stress or eating and he have enough sleep. This is the ideal time to check blood pressure. So for evaluation of blood pressure patient, from the clinical point of view, for every patient, blood pressure is high, as in front of us. From the clinical point of view, we should ask the patient about 2 issues. One, when we take history from the patient, to rule out what's called cardiovascular risk factors. And I will come through. And all of us, we should know from our heart what are the cardiovascular risk factors. And we should ask the patient about. Second one, how to assess the target organ damage, or what's called target organ failure. This by clinical exam. The doctor, he will examine the patient to rule out target organ damage. Number 3, if the patient has secondary causes for hypertension, and this is very rare, up to 5 to 10%, and usually endocrine diseases, like acromegaly, Cushing, something like that. We'll not touch this point now. So, any hypertensive patient, reading is high. We assess the patient from the clinical point of view. How to assess this patient? I'm coming for this. First one, ask the patient about the cardiovascular risk factors. If any patient blood pressure is high, systolic more than 140, diastolic more than 90, and the patient doesn't have risk factor, I will say what this risk factor, and the patient, when we examine him, he doesn't have organ damage. Again, any one of us, sorry to say it like that, blood pressure now is high. I will assess 2 issues. I will ask the patient about cardiovascular risk factor, and we examine if he has or he or she have organ damage. If the patient doesn't have both, no cardiovascular risk factor, no organ damage, we cannot label the patient hypertension. He is not hypertensive. Whatever the reading, you can imagine some of the patient coming and the reading is 180 over 110. It's high, but still no organ damage, and the patient no risk factors. Reassure the patient, okay, don't say that you are hypertensive. And I will come for some of malpractice. Till now it is done here in Kuwait and in other places, the assessment of patient and the management of patient. I will come after a few slides, very, very important slide. We needed to apply it here and in every place. So once the patient, no organ damage, no risk factors, please and please and please don't label the patient he or she hypertensive. Unless the reading is persistently elevated up to 6 visits through 3 months. Persistently, it's when you check the blood pressure, every time it is high. Okay, but 1 reading, 2 reading, don't label the patient to be hypertensive. Most of these patients, once you reassure the patient, calm the patient, send the patient home, no treatment. Okay. So what are the cardiovascular risk factors? All of us from doctor side and nursing side, we should know. 8 cardiovascular risk factors we should ask in a hypertensive patient about this one. First, if the patient is known to be hypertensive, maybe the patient he known to be hypertensive and he is already taking medication. So the first one, are you hypertensive? The patient, he will say yes or no. Are you taking medication? He will say yes or no, and what type of medication. So this is the first one. 1 risk factor, will ask the patient about hypertension. 2, the very common one, patient may be ischemic heart disease. You should ask the patient about he have any history of ischemia, history of previous MI, history of balloon, history of CABG before, means something related to the heart, which is ischemia, if the patient has ischemic heart disease before. Number 3, which is a very common, diabetes, if the patient known to be diabetic or not. Number 4, which is very common, obesity, BMI more than 30, or the patient in front of us looks obese. So this is one of the risk factors. The third one was dyslipidemia, cholesterol, or patient he knows lipid is high or cholesterol is high. The one common also which risk factor, we should ask the patient about smoking, if the patient he or she is smoked or not. 1 risk factors which is positive family history of hypertension. And the last risk factor, the age itself. For men above 55, for women above 60 years. This is one of the risk factors. So 8 risk factors in front of us, we should ask the patient about these. If the patient hypertensive, he has obesity, diabetes, dyslipidemia, smoking. What is the importance of that? Why we ask the patient about that? Because if the reading is high, say 160 over 100, and the patient has 2 risk factors, not only 1. Patient has 2 risk factors, means the blood pressure now is high, and the patient is smoking and he has diabetes. We'll give treatment, we'll start treatment. But if the patient has only 1 or no risk factor, we'll not start the treatment. This is very important from the clinical point of view. So 2 risk factors, and yes, come doctors. come here with the So 2 risk factors with the blood pressure is high will start the treatment. No risk factors will not start the treatment. Okay? Why hypertension per se is a risk factor? Any patient hypertensive, whether he is in treatment or not in treatment, per se cardiovascular is a cardiovascular risk factor. Because hypertension per se persistently elevated, it can affect the number one, it can affect the brain. That's why some of the patients, when the blood pressure becomes so much high, especially if persistently high, they have stroke, hemorrhagic stroke, TIA, or they have hemiplegia. So it can affect the brain, leading to TIA or stroke. It can affect the eye, and our ophthalmology doctors, they can lead to what's called a hypertensive retinopathy. I will show some slides. It can affect the heart, leading to heart failure or left ventricular hypertrophy or ischemia. It can affect the kidney, leading to renal failure, affect the vessel, leading to peripheral vascular disease. So the second one, which is important during the examination of the patient. First, I said, rule out cardiovascular risk factor. We should ask the patient about the 8 cardiovascular risk factors, as the previous slide. Second one, end organ damage. When we examine the patient, how to rule end organ damage. Now, if the patient in front of us, especially if the systolic more than 180, systolic more than 180, and diastolic more than 120, patient in front of us, systolic more than 180, and diastolic more than 120. This patient, we should examine him from up down to rule out what's called end organ damage. Because if any one of the end organ damage present with this reading, patient directly needs ICU admission. Okay? So systolic more than 120, diastolic more than 120, and there is end organ damage in the clinical when we examine the patient. Patient needs ICU admission. What is end organ damage? We can take it from up down. Up from the brain. If the patient looks in front of us drowsy, patient is drowsy, agitated, semi-conscious, or he has semi-coma, this means he has disturbed level of conscious. If the patient from the brain wise disturbed level of conscious, might have hemorrhagic stroke or TIA or hypertensive encephalopathy. This is the first one. If the patient from the conscious level disturbed, agitated, drowsy, or whatever, this from the target organ damage of the brain. Number 2, we should examine the retina. And this is unfortunately from the clinician, I know they doesn't do this procedure. It is very, very important with hypertensive patient, the reading is above 120 systolic or 120, to examine the retina to rule out hypertensive retinopathy. I will show some photo. Grade 3 and grade 4. Malignant and accelerated, yeah. So we should examine the retina. Once we saw in the retina, grade 3 or grade 4, needs ICU admission. Yes, also. Number 4, we'll examine the heart for this patient. The heart, when we examine the heart because this patient might have MI. That's why in all hypertensive patients, systolic above 180, diastolic above 120, we should do ECG. It's a must. We should do ECG. Even if the patient, there is no chest pain, it is a must to do ECG. Because if the ECG shows LVH, left ventricular failure, end organ damage regarding the heart. Number 4, we should ask for renal profile, urea and creatinine. Because if the patient has renal shutdown, urea is high, creatinine is high, the patient has renal failure, needs ICU. Last one, if the patient blood pressure is high and she is pregnant, she needs ICU if she has eclampsia or preeclampsia. So the end organ damage, CNS, brain, patient might have stroke, TIA, or encephalopathy. Retina, grade 3 and grade 4 retinopathy, I will show some slides. Cardiovascular, if the patient has pulmonary edema or acute coronary syndrome, left ventricular hypertrophy or aortic dissection. from renal if he has acute renal failure, and from pregnant lady if she has eclampsia. So evaluation of the patient for every patient, especially the blood pressure systolic above 180, diastolic above 110. This investigation is a must. ECG. I will show some ECG when the patient has hypertension. We should do ECG. Once the ECG there is changes, especially ST segment elevation or depression, we should ask for cardiac markers, troponin and CKMP. Also is very important. Third, chest X-ray, because if the patient has pulmonary edema, we can show in the chest X-ray cardiomegaly and some pulmonary congestion. And renal profile, serum electrolyte, if the patient has renal failure. If the patient drowsy or has hemiplegia or CNS signs, we should ask for CT brain or MRI brain. Okay. This is the investigation needed for emergency patient. This one of the ECG, just very few. If some ECG changes, in this specific ECG, the cardiac axis here is left axis, because here the R is up, the S is down, this left axis deviation. With left axis deviation, in V2, there is deep S. Deep S, I will not make, just will see with Sister Minnie. From the next, just there is a paper who is interested for ECG. We have a specific course for ECG, basic ECG course, and there is advanced one. Who is interested, just register the name with Sister Minnie, and will do this courses, basic ECG. It will take 5 sessions or 6 sessions. We can, if somebody interested about the ECG. In this specific ECG, there is left axis deviation and what's called positive sum criteria. Diagnosis of this ECG, left ventricular hypertrophy, LVH. Once the patient has LVH in ECG, this patient should be admitted to ICU because he has one of the end organ damage, which is LVH. That's why it is very important from the clinical point of view. Any hypertensive patient is taking treatment, we must do ECG at least once per year. Because maybe he has the first one normal, second one is normal, but sometimes it comes to the same one, which is LVH. Once the patient develops LVH and he is hypertensive, we should so much aggressive in treatment in this specific patient, because very soon he will develop heart failure. Okay. Second one about the retina. When you examine the retina, this is, we have our colleagues from ophthalmology. They have more experience than us, for sure. This is the normal fundus, and if we'll see, this is the optic disc. It will be have well-defined margin, and this is the vessels, and all the retina here. There is no any hemorrhage or any exudates. This is the normal fundus. We should examine the patient, hypertensive patient, but if you look for the second one, you will see here lot of hemorrhage. All of the red one, this hemorrhage, and soft exudates. This is the yellow one, soft exudates and hard exudates. This is grade 3 hypertensive retinopathy. If the patient hypertensive and he has in his eye this color, patient should be in ICU. Grade 4, normal fundus as the previous one, and if the grade 4, we'll see this is papilledema, which is the swelling of the optic disc. Optic disc now is not there. This here, well-defined disc. This one. Here, there is no disc at all. This is what's called papilledema. Patient needs ICU. Hypertensive emergencies, I said, if the blood pressure is more systolic more than 180, diastolic more than 120, and there is one end organ damage, previous is non-accelerated and malignant hypertension. Forget about the name. Any patient with end organ damage, ICU. And we should control the blood pressure by IV medication, not oral. This is very important from the clinical. If the patient has end organ damage, directly we can adjust in emergency room for a while until the bed is ready for ICU, and they will shift the patient to ICU. During this time, we should give IV medication, not oral medication. Okay? This is for the malignant or what's called a accelerated hypertension. What about if the patient, his blood pressure, he or she, systolic above 180 and the diastolic above 120, but the patient is totally asymptomatic, no risk factor, no end organ damage? How to deal with this patient?
We will recheck the blood pressure.
We can reassure first, recheck the blood pressure, and if he needs, we'll give him oral medication, not IV. and he or she needs ICU admission. So if the patient is totally asymptomatic, no risk factor, no end organ damage, we can reassure the patient and we can give oral medication. When we give the oral medication, one of the malpractice till now in most of the countries, and here in Kuwait still it's applied, and maybe applied here also, maybe. When the blood pressure is high, I said no risk factors, no end organ damage. Why you treat the patient? Reassure the patient, send the patient home. No emergency treatment. If there is no end organ damage, if there is no risk factors, don't give the patient any hypertensive medication. The malpractice what's given, 2 medication usually given from the physician, which is nifedipine, the generic name, which is known as Epilat or Adalat, or captopril, which is Capoten. And the problem is given sublingual, not oral. Please and please and please, I can say please till tomorrow, don't give nifedipine or captopril sublingual. It is obsolete, not approved by any guidelines. It is not approved by FDA, but unfortunately it is one of the common malpractice till now. Don't use it at all. If the patient needs nifedipine or captopril, give it oral, not sublingual. Why? Because sublingual, if it's given through sublingual route, is very fast action. It can have severe drop in blood pressure. If the blood pressure, say 180 systolic, and within few seconds, now became 100, the patient will go into hypoperfusion, brain and heart. I saw this twice during my practical life. One in Amiri Hospital long time ago, and one in Hadi Hospital. In front of me, after giving sublingual aid, patient developed TIA. Okay, because the severe hypotension is happening. So please and please don't give these 2 medications sublingual. If you need it, give it oral. So patient with end organ damage, we need parenteral patient. He can give it medical treatment if there is no risk factor or if there is no end organ damage. The common all of these types of patient needs ICU, hypertensive encephalopathy, patient with a stroke or TIA, pulmonary edema or MII, with aortic dissection, acute renal failure, with eclampsia. All these types needs ICU. This is the very important slide. Please and please, captopril and nifedipine, don't use it sublingual. Not approved by FDA, and it can lead to stroke or MI or severe hypertension. Don't use it at all. So the goal for blood pressure, this is maybe the last 2 slides, is to control. If we need to treat the patient and we decide to treat the patient after label the patient as hypertensive, the goal usually will keep the systolic blue 140, diastolic blue 90. This is the goal, usually blue. If the patient diabetic, we'll keep blue 130 systolic and 80 diastolic. This is the goal when we manage the patient by oral hypertensive medication. During the treatment, very, very important, most of the clinicians, most of the doctors, unfortunately, we don't give the patient a lot of time to just advise the patient about lifestyle modification. You can imagine lifestyle modification per se. If the patient losing weight, if the patient taking a healthy diet, if the patient do exercise, they can decrease his blood pressure and it can achieve the goal without any oral medication. But unfortunately, most of us will hurry and will give the patient medications. So please do our best in the clinic to advise the patient losing weight, to advise the patient making more exercise, to advise the patient take healthy life. So the more one non-pharmacological treatment, which is lifestyle modification. In short, you can imagine decreasing weight up to 10 kilo can decrease the systolic from 10 to 20 milligram mercury. Per se, just only decreasing weight. Avoid sedentary life. We should do exercise. This every other day, we should make some of the exercise. Yes, this is very important. Healthy diet. Give up smoking, also one of the very important. and thanks to see you inshallah. Before just to finish, Dr. Muhammad from Novo, he will introduce himself and he will give us a short note about one of the new medications for the diabetes. Just reached here in the Kuwait market 2 weeks ago. Just he will give an idea about this medication. You can switch on the light, please. Sorry. Yes, for
هو accelerated ده المقصود. قال لك عشان تدخله ICU اللي هو 180 120